So the KEYSTEP-008 study is a platform Phase II randomized clinical trial, and this study was dedicated to patients with MSI-H or deficient mismatch repair metastatic colorectal cancer. Basically, there were two cohorts in the study. In cohort A, patients were pretreated with the three main chemotherapy agents, fluoropyrimidines, irinotecan, and oxaliplatin, and anti-GFR monoclonal antibodies if clinically indicated. And in this cohort, the patients were randomized to either standard of care pembrolizumab or a combination of pembrolizumab with the anti-CTLA-4 monoclonal antibody Quavonlimab, and this is a co-formulation. So basically, in this heavily pretreated patient population, the overall response rate was higher with the combination, 45% overall response rate versus 30% with pembrolizumab alone, and there was a numerical increase in terms of efficacy endpoint, including progression-free and overall survival. However, the patient number, 60 patients per arm, was not sufficient to show any statistically significant difference. Also, it is important to note that nowadays the use of immune checkpoint inhibitors is recommended by all major guidelines in the first-line setting, and so cohort B of the study investigated different pembrolizumab-based combinations in the first-line setting in patients not previously treated for metastatic disease. And so the 5 arms of the second cohort of the study investigated pembrolizumab alone or in combination with other agents, including Quavonlimab, as in cohort A, but also other agents such as the anti-LAG3, favezelimab, and the TIGIT, vibostolimab, and also the ILT4 inhibitor acting on macrophages receptor, MK7840. So basically, in these cohorts, there were no significant differences in terms of response rate or progression-free survival, overall survival. So basically, in this patient population, actually combining pembrolizumab with an additional immune checkpoint inhibitor didn't provide any additional benefit compared to monotherapy with pembrolizumab alone. Of course, we know that today the standard of care for most patients is the combination of ipilimumab and nivolumab in the first-line setting. So, of course, this is the current standard of care, and additional agents are needed to further improve the outcomes, but the outcomes are really, really good with the combination of ipi-nivo. So it will be difficult to really achieve better results than the current standard of care.